So welcome everyone. And Chad, if you're able, I'll let you go ahead and do a welcome also.
Yeah, absolutely. Thank you, Barbara. I just wanted to, again, say thanks and appreciation to everyone that's taking time out of their busy schedules. We know and understand, particularly now with everyone dealing with issues related to COVID, that our time is even more precious and we are spread even thinner than we always have been. So again, thank you for, again, demonstrating your commitment to improving maternal and neonatal health in the state of Oklahoma. And we appreciate you being here and look forward to the conversation.
Thank you, Dr. Smith. So moving to the next slide, just a brief overview of our agenda. We're going to have a few updates from OHCA and OSDH, going to provide some information on the Oklahoma Maternal Health Task Force work groups. We'll have a presentation on the STAR Clinic by Dr. Pierce, and Sarah Johnson will do a presentation on our patient resources. Dr. Tara Jackson from OSU Project ECHO is going to give us a presentation on the high-risk pregnancy echoes, and then we'll provide a brief update on the Oklahoma mothers and newborns affected by opioids. So I am going to turn it over to Christina Foss, who will provide some updates for the Oklahoma Healthcare Authority. Thank you, Christina.
Thank you. Can you hear me okay?
Yes, we can.
Okay, perfect. Just wanted to make sure I asked before I started talking. Thank you for having me. I'm here just to give a brief legislative and budget update on the Healthcare Authority and where we stand. So as you all are aware, we're operationally preparing for Medicaid expansion. We'll begin enrolling new members July 1st of this year. And this session we'll be really monitoring exactly what that expansion funding looks like. So, we don't have very many bill requests this year. Most of them are just carryovers from last session since it was cut short abruptly. So we are really just watching and, monitoring where expansion funding sits. So our estimate is still at $164 million for the state share to expand Medicaid. And that was the same estimation we gave last session as well. And so we'll be, like I said, monitoring what that looks like. There are a few different funding strategies that we know the legislature is looking at, and we will have our budget hearings next week with both the Senate and the House. So besides that, we have a couple of budget requests that we're looking at. One is to expand adult dental benefits for the expansion population. Well, it'll be for our entire population of adults that we cover, but having that for the expansion population will be very beneficial. And then our other budget request item is looking at some additional treatments for pain management, so like chiropractic and physical therapy. So those are the two budget request items aside from the expansion mandate that we have that we're looking at this session. So like I mentioned, our bill requests are very few. We just have a couple of carryover from last year, pretty minor kind of cleanup language type things. Besides that, we're looking at our tribal partners shared savings program again. And I'm trying to think, we don't really have any other budget requests. I'm trying to think what else there is. I think expansion, like I said, is just our biggest thing we're looking at. So that's really all we have going on right now. Transition to managed care as well. I know that I think Trailer gave you all an update on where that sat at the last meeting, but we are still examining the bids that we got in and should be awarding contracts within the next few weeks. So be on the lookout for that as well. And I'm happy to answer any questions.
Christina, this is Barbara O'Brien. Can you give us there's a lot of providers on this meeting. Can you give us some sort of idea of how things will change as the managed care, the MCOs are integrated into Medicaid here in Oklahoma?
I can give a very general sense. I think with any specific questions, I might turn to if there are other agency employees on the line, since operationally that's not an area I deal with. But we, as we transition to managed care, like I said, right now we're still looking at all the bids that we got in. Bids closed in December, and we'll be awarding those contracts in the next few weeks. And then after that, we will look at, our future partners and start kind of the readiness review process with a targeted start date of October 1 to pull in those populations that we're looking at utilizing for managed care. And so those populations are our children and pregnant women, the expansion population. Those are the main groups that will be transitioning over to managed care. We're hoping to have quite a few, plans to choose from. Federal regs require that we have at least 2 that members can choose from, but I think we're hoping to award 3 to 5. Again, I'm not part of that review process of what those bids are, and so I can't speak directly to that, but we're also still in our cone of silence phase for that. So I mean, generally that's what it looks like, but if there are any specific questions, I can try to address those, or I can find out an answer and get back to you all. Or again, if there's any other agency employees on the line that want to give a better overview, certainly.
Rather than ask a question, I already asked Mike Herndon a question that I suspect other providers will have. So I may be appropriate to share here. My concern was with multiple different agencies providing coverage, that the rules for what was and wasn't covered would vary by group that covered the patient. Mike assured me that such decisions would continue to be done in such a way that the answer was the same across the board. So I found that reassuring. I hope that stays true. Yes.
Each plan will be required to cover the services that we already require, the services that are in our state plan. So any kind of state plan amendments obviously has to be done through the agency. So MCOs will have to cover all of those benefits that we currently cover. They can add additional benefits, but they can't take away.
This is Teresa Stevenson with the Department of Mental Health and Substance Abuse Services. I just wanted to add to the Healthcare Authority report that I've been on a couple of the waiver meetings, and opioid treatment is now Medicaid compensable, and its services for opioid use disorder, as well as adult substance use treatment services for residential, are now also Medicaid compensable. So I just wanted to add that.
Thank you so much for adding that. Yeah, we got the IMD waiver was approved recently, and I know both agencies are very excited about that.
And Barbara, and everyone on the group, this is Shelley. And I think that, at a future meeting after the award has been made, and we know more about, obviously who is going to be providing the services, and then we could come back with more of those kinds of details that you're interested in. So I think, we may want to plan that for a future meeting.
Yeah, I think that's a good idea, Shelley. We can either incorporate it into one of these meetings, or if we think it needs a longer time, or a dedicated meeting for it just itself, we can plan that as well. I'm sure you guys are going to be doing some outreach things related to this that are educational for providers. But yeah, I was just thinking we can also include that for our next meeting and add additional meetings if we need to. Thanks, Shelley, and thank you, Christina and Teresa. Are there any other questions? We'll go ahead and move to the State Department of Health. Joyce Marshall is going to provide an update for OSDH.
So first, I know if you mention the Department of Health, the first thing everyone wants to know is the latest in relation to COVID. So I'll just give you a few of those facts. I know we're following it and living it, so I'm going to keep it brief. But some somber facts. Over 2.9 million tests have been completed to date for COVID. Over 358,000 have tested positive. We've had over 3,000 deaths, which is very sad in our state. And we currently have over 36,000 active cases. We've had over 20,000 cumulative hospitalizations. So it is definitely taking its toll on our state. We've also had close to 1,800 cases reported by women who were pregnant at the time they tested positive for COVID-19. So it is also affecting our pregnant population, and we are following those to see what the effects are. Additionally, though, there is hope. Close to 200,000 total doses of the vaccine have been given, 197,820, over 169,000 primary and over 28,000 secondary. And hopefully we'll begin to see positive cases decrease as more are vaccinated and we become closer to herd immunity. And I know that can't happen soon enough, although it is going to take some time for that to take effect. But now in relation to more of the good things that are going on, there is both national and state emphasis on maternal and infant health, and it's important to the state and the nation. At the national level, the U.S. Department of Health and Human Services recently came out with an action plan to improve maternal health in America, along with the Surgeon General's call to action to improve maternal health. It's very similar to our Oklahoma Maternal Health Task Force strategic plan that was recently completed with stakeholders statewide, many of you on this call, and through funding from HHS Maternal Health Innovation Grant. Both have set similar goals to work that are complementary with one another to reduce maternal mortality and morbidity. The national plan has 4 goals, and those are to achieve healthy outcomes for all women of reproductive age by improving prevention and treatment, achieving healthy pregnancies and birth by prioritizing quality improvement, achieving healthy futures by optimizing postpartum health, and improving data and bolstering research to inform future interventions. And the 3 main measures that they're looking at to see success will be maternal mortality, low-risk cesarean delivery, and blood pressure control in women of reproductive age. In Oklahoma, our 4 priority areas that you can see on the map is similar, and it's improving access to appropriate care and maternal health programs. B, to expand mental health, substance use, and social services. C, implementing innovative technology and data systems. And D, to address racial disparities. Some key measures we will be reviewing are maternal mortality, severe maternal morbidity, access to prenatal care, and disparities, along with pregnant women with specific health conditions, most cited in maternal deaths, such as diabetes, hypertension, asthma, obesity, and cardiac problems. The status quo is not acceptable, and we want to work together to improve the health of our moms and babies in our state. Your work together in this area is beginning to show promise, as after 4 years of significant increases in maternal deaths in our state, preliminary data is suggesting that we are starting to turn the tide. And on that note, I want to turn it over to Dr. Rodney Edwards and Dr. John Stanley, our Oklahoma Maternal Health Task Force chairs, to talk about some exciting next steps in the work towards implementation of Oklahoma's plan to reduce maternal morbidity and mortality throughout our state.
Yeah, thanks, Joyce. Wanted to go over who the co-chairs were for the groups and who the agency leads were for each of those 4 groups you just talked about. Work Group A, access to appropriate care and maternal health programs. The co-chairs are Christine Taylor and Kate Arnold, and the agency lead is Jill Nobles-Bodkin. Group B, mental health, substance use, and social services. The chair is Stephanie Pierce. The agency lead and vice chair is Barbara O'Brien. Work Group C, innovation, technology, and data systems. Chad Smith is the chair. Jeff Northcutt is the vice chair. And Joyce Marshall is the agency lead. And fourth, the racial disparities group. Doctors Latoya Smith and Angela Hawkins are the co-chairs, and Kamisha Busby is the agency lead on that one. So thank you to all of those individuals for volunteering / agreeing to lead those groups. You should be getting within the next couple of weeks probably invitations to meetings from those individuals. If you've already voiced a specific interest in one or more of these groups. If you haven't voiced interest so far, please email your interest of which of these groups you'd like to work on to Joyce at joycem@health.ok.gov. And she will get you in touch with the appropriate people to put you to work. So here we go, getting some stuff done with this group, hopefully.
Thank you, Dr. Edwards. Joyce, do you have any other updates?
No, I think that's it for now. Thank you very much. I think we can move to the Star Clinic.
If someone can put Joyce's email in the chat, we can.
Working on it right now.
Thanks. Or you can also email me, Barbara O'Brien, and I can forward to Joyce. So thanks so much. Are there any other questions before we move to our next item on the agenda? Okay. I'm going to turn it over to Dr. Stephanie Pierce, who is an assistant professor of maternal fetal medicine at OU Health Sciences Center and the medical director for OMNO and the director for the Star Clinic. And she's going to give us a presentation on the Star Clinic. So go ahead, Dr. Pierce, and I'll let you, we will drive your slides for you as you're giving your presentation.
All right. Thanks, Barbara. As Barbara said, I'm Stephanie Pierce. I'm one of the maternal fetal medicine faculty at the OU Health Sciences Center. And Barbara had given me the opportunity to give an update and kind of give a little bit more information about what we're doing in what we call our STAR prenatal clinic at OU. So I'll start here with the name. So STAR Clinic stands for Substance Use Treatment and Recovery. And the goal of our STAR Clinic at OU is to provide comprehensive specialized prenatal care for women with substance use disorders in pregnancy, and to do that in a collaborative environment where we emphasize coordination of care with our supportive psychosocial services and substance use treatment providers. So we know that a lot of these women, as we all know, really have had some negative interactions with the healthcare community in the past, and oftentimes are coming into their pregnancy feeling judged, feeling unwelcome. when they seek prenatal care. And so our goal is really to provide, both excellent prenatal care for these women that addresses all of their needs and all of their issues, but also to do that in a really welcoming environment so that they feel comfortable with us and feel comfortable coming to us for their care. Next slide. So what you'll find here at the STAR Prenatal Clinic, we're located within the high-risk OB clinic at OU. So this is kind of a part of our regular high-risk OB clinic that's, again, dedicated to these women with substance use disorders. So this is located at the OU Children's Hospital. I know that, some of the providers here may have referred patients to us either to the STAR clinic or just for maternal fetal medicine consultation. So this is all occurring at the same place at the Children's Hospital. And the things that we provide when patients come here to the clinic, so we of course provide full prenatal care by maternal fetal medicine specialists, including myself. We do specialized OB ultrasound in our clinic. And what's I think really making a difference for these patients is that we have an in-clinic dedicated social work team. And that's allowing us to really, both provide assistance with any needs that the patients have in terms of social needs, financial, transportation, but also to really allow them to connect with behavioral health providers, with substance use treatment providers in the community, as well as our social work team can also provide behavioral health services. So that's been really important for our patients to have our social workers in the clinic so that they can see them at their visits. They are really involved in their prenatal care, and they can help us to kind of provide for those additional needs that these patients often have. We also, prior to COVID, had been offering group education sessions. We've kind of put that on hold right now, but hopefully we'll plan to resume that once we're able to gather safely. And then we're also working on getting access to peer recovery support specialists, which our patients will be able to access just to help them on their journey of recovery and during their pregnancy. As far as what a visit looks like in the STAR Prenatal Clinic, so here's an overview of their initial visit. They'll have an OB ultrasound if needed. And then of course we do the interpretation and counseling here. They'll have their prenatal visit where we discuss their medical and obstetrical history, their substance use history, and what their goals are for treatment. And that's really when we can assess whether they're in treatment for substance use disorder. If they already are, of course we encourage them to continue that. If they're not, then that's when we, really help them to get plugged in somewhere. And we have a lot of wonderful community resources here in the city that we can connect them with. And then we provide evidence-based prenatal care and creation of an individualized plan for each patient's pregnancy. Each patient also has a meeting and an intake with our social work team at their first visit as well, so that our social workers can assess their needs. And then again, help to either establish plans or encourage that they continue with their substance use treatment. As far as what a return visit looks like, again, OB ultrasound if needed. So this would usually be in the form of fetal growth assessments, biophysical profiles, depending on the individual patient situation. They'll have their prenatal visit. So we continue with their full prenatal care. Of course, we can also manage any of their maternal and fetal comorbidities, diabetes, hypertension, congenital birth defects, among other things, delivery planning. And then we also make a point to come up with a postpartum pain management plan as well, particularly for our patients that are on medication-assisted treatment that we suspect might have some issues with pain control postpartum. And then, of course, we always address contraception as well. Throughout the pregnancy, we continue to coordinate care with our patients' substance use treatment providers as needed. So if their providers have questions about their buprenorphine or methadone dosing, we'll communicate with them. And then most visits, they'll also visit with our social work team as well, depending on what's going on with the patient at that particular visit. As far as how to refer patients to our clinic, so one of the most important things, and I know this group has talked a lot about this, is screening all pregnant patients for substance use disorders. And the particular screening tool, matters less than just using a screening tool. And there's multiple validated screening tools that can be used. The NIDA quick screen, the 5 Ps are 2 common ones that are used. Then when a pregnant woman with a substance use disorder is identified, we're always happy to see her. And so you can send a referral form to our STAR prenatal clinic. This is the fax number. And again, for any providers that have sent us patients previously for other issues like diabetes, high blood pressure, et cetera, this is the same fax number, the same referral form that you would use to send for any other high risk issue. We're also working together with the Department of Mental Health and the Health Department on an app-based referral system, which we hope will come to fruition in the not too distant future. And then this is our clinic phone number as well. So you can always call if you have any issues with getting a patient in to see us. And you can always ask for me, Dr. Pierce, by name, if any issues at all. And I'm more than happy to assist with scheduling. And then I've got my email address here. And Barbara, if you wouldn't mind just sending out the slides to everybody so that they have this information, that would be great.
Yes, Dr. Pierce, we will do that, and we'll have those available to everyone. We also, and there's a link on the agenda that has a web page within our website that has links to the referral form, and the STAR Clinic also has an informational video that they've created. So we have that link available on our website as well. It's on the page. The link to the page is included in your agenda.
Excellent. And then we are, of course, very grateful to our generous funding partners as well, the Department of Health and the Department of Mental Health and Substance Abuse Services.
Thank you, Dr. Pierce. I see that there's a question from Dr. Lovelace at St. Francis, who asked, is there a STAR clinic at OU in Tulsa as well?
That is a great question. We do not currently have that set up, but I think expanding to other areas of the state is something that we are definitely looking at. And Tulsa would, of course, be one of the natural choices. So we will keep you posted on that one.
We learned recently that there was such an interest and are going to pursue that. So yeah, agreed.
I'm going to now turn it over to Sarah Johnson, who you all have met at previous meetings. Sarah joined our staff in the end of March as our maternal peer navigator, and she's going to provide an update for you on some resources that are available to hospitals that we've developed. So Sarah, I will let you go ahead and present.
Thanks, Barbara. Like Barbara said, we have a few things that we have developed over the last several months that we want to offer to hospitals or to our partners in general. And a few of those are in presentation form, and you can see here on the slide under community outreach, we've got several presentation opportunities that we hope that our partners will want to take advantage of. We'll have a lot more information about these on our website, on OPQIC's website, so you can access that there. Hopefully in the near future, in the next few weeks, that should all be up and running. But for now, I'll give you just a brief overview of each of those opportunities. First, we have options for hospital departments. We have done presentation at a couple hospitals well, actually just one hospital, but in 2 different departments. And so we've got opportunities there for hospitals to take advantage of. Those can be anywhere from 30 minutes to an hour, depending on what the hospital needs or wants. We are very flexible on that. And we can tailor that to whatever the hospital would find the most useful. Also, we can do community partner presentations. Barbara and I have done those as well in the community over the last several months to different partners that are just interested in what we're doing with maternal health in general. So if there's any community partner that you think would want to hear from us and would like to possibly, you know, mostly they're usually looking for opportunities to partner, then we are more than happy to do those presentations as well. And we've done those for, usually they last about an hour, but we can tailor that to anything that anyone would need. And then also, most of you have probably already attended a deep dive learning workshop, which is what we're calling the presentation that I have done at like the summit, where I tell my story in detail and the whole story from beginning to end. And then Barbara can do a timeline after my story, and we go into a lot more depth about what happened and what things could change for others in the future. So that is kind of our menu that we're calling it, of community outreach opportunities, or you know, any kind of presentation opportunities that we've got. So if you guys are interested, you can let us know. You can always email me or Barbara, and we can get you more information if you need it. And then also, we are still doing patient partner meetings. I'm doing patient partner meetings. So I've got 4 other advocates that are meeting with me currently, and I'm actively looking for more. So if anybody knows of anyone who would like to join in our meetings, we are more than welcome, or hopeful to welcome anyone else. So that is going on now. And then we also have a few new resources that I'd like to show you guys that we've been working on the last few months. First off, this is a draft, and it's what we're calling our patient resources flyer. It's something that I would like to have the opportunity to share with any mom that's being discharged from any hospital in Oklahoma. So after birth, these are some basic resources that I find helpful, that our team has kind of vetted for the best opportunities for connection. So first of all, breastfeeding resources, and then secondly, we've got what's the website is called newmomhealth.com. It's actually the 4th trimester project, which you may have heard in the past, but they have a lot of web resources for new moms and health related questions and family support. They connect people to each other. It's kind of well, they call themselves a village for mothers, so that can tell you a little bit about them. And also we have connections to the Postpartum International website, which is for mental health support. You can get connections to your local resources through that website. You can call the 1-800 number in English or Spanish. Also, we're going to put on this flyer, we put on this flyer our website, which will have a longer list of resources. It already has a lot of resources currently that can be helpful to patients, but we're going to expand on that. And then, sorry, my chat is in the way there. We did create an email that is going to be on our website that will be for anyone who needs extra assistance. So if somebody's looking at this and they just don't know, they're needing some assistance in some way, but they're not sure exactly where to find it, they can always send us an email and we can help direct them to the proper assistance. So I saw that someone asked if they could get one of these, and absolutely, we hope that we can get these out to anyone and everyone who would like this. Like I said, my personal goal is to have these given to every woman that leaves the hospital after having birth, or even after, if she doesn't get it at the hospital, maybe she gets it at her pediatrician's office for her baby's first checkup, or if there's another way to get it into a mom's hands. I'm open to any opportunities that are out there, but that's kind of what I would like to see happen And we call this a draft because we're open to suggestions on it. And if you guys have any suggestions or recommendations, we're open to that. So please let us know. You can always post those in the chat. You can let us know now if you'd like, or you can send us an email in private if you'd like to do it that way. But this is something that we've been working on and we're really excited about it. I know our patient partners are super excited about it. They helped us to identify these needs. And yeah, I'm excited to get this out into the communities. So we can go to the next one. Denise, thank you. This is another document that we have developed that we're hopeful will be able to be used in the hospitals as well. We're calling it a clinical summary, and what it really is kind of a discharge summary for patients. It can be used for every patient, or it could just be used for patients that have some sort of an event that would call for some extra detail or something that's put into writing so that they have it for reference. And we also see that this could be something that would be printed on the backside of the resources flyer, and the patient could have some information about their birth on the backside, and then some resources to mental health, healthcare, basic assistance on the other side. So that's kind of where we're at. We're open to suggestions on this as well. We have presented this to a couple other places. We took suggestions from them and edited and changed it a little bit based on that. So we're open to anything that anyone else might see. Barbara, you might have some extra that you want to add about this. Not sure if I got all the details there.
Yeah, no, sure. That's great, Sarah. What this really is, like Sarah said, a clinical summary for women and their families. Hopefully everyone, especially women who have experienced some sort of unexpected event or adverse event or anything outside of normal, would have a provider explain things to them. This is what happened. And, it could be even that we needed to give you blood because of this reason. It doesn't have to be a huge ordeal. That we needed to do a C-section because of this reason. During those conversations, you can use this as a written resource that has everything kind of summarized on it, so that when a woman goes home and maybe they're not going to remember everything that you're telling them, especially if they're in some kind of situation that they're traumatized. So this is a written copy that they can keep. And, like in Sarah's case, she got transferred to another hospital, but she didn't even know what had happened to her. So being able to provide another hospital or even any other clinicians, an emergency room that a woman contacts with after discharge, being able to give this type of information can be helpful. So we are going to have it as a Word document so that you can adjust it if you all have any kind of feedback to us on this. I've received some text here for this, for example, adding the postpartum hemoglobin. If there's anything that you feel like we should also add to this, we're open to feedback. That's why we wanted to give this to you. But really, this can be used for all women, but especially we feel the need to give to women who've had something unexpected happen or anything that needs to be explained further, and using this as a written tool. As Sarah said, we can include it on, you could print it on the back of the other one. Denise, if you'll go back to the previous slide real quick. just wanted to also mention with this, these were resources that we felt like almost anybody might need. And these are probably the most needed resources. I would encourage you all to look at this New Mom Health and Family Support, this New Mom Health website. It's done by the University of North Carolina at Chapel Hill with the 4th Trimester Project, and it's an excellent resource. But what we've heard from our other patients in the patient partner group is they left after their experience and they just had no idea what had happened, and they didn't know how to ask questions and how to reach out, and we're left kind of just in this sense of unknown, and that really added to their experience, that it was not a positive thing that was added to their experience. So this is something we want to ensure that women do have a place to reach out, and even all women. So I have a couple more slides here real quick, and then we'll open it up for some questions. So just wanted to remind you all, you may have heard about the CDC Hear Her campaign. This was released in the summer, I believe in July, and this campaign, the website is below. If you'll go to the next slide, it talks about the goal is to emphasize listening to women and hearing concerns. So this applies to providers that care for women and families. It also applies to their friends and families and the community in general. So this is kind of like a change that we want to make so that everyone is listening when women have some sort of concerns. Sometimes we brush them off, like a mother might say, well, you're probably just tired. You just had a baby. Everybody feels this way. Everybody has headaches. So instead of brushing those complaints, those concerns off, that we listen to them and direct them to where to seek help. So if you'll go to the next slide, part of the Hear Her campaign is to educate on urgent maternal warning signs. These were developed by the Council on Patient Safety and Women's Healthcare, and we encourage providers to start educating on these, and that the community would know these warning signs. But this would begin during pregnancy. Some of these are specific to postpartum, some are more specific to the pregnancy, prenatal period. So you can tailor your education depending on at what point this woman is in this whole continuum. The next slide shows a PDF, partial PDF, we don't have the full one here, of these warning signs, and we encourage providers to even print these off and provide them in prenatal care visits or postpartum visits. You can also make a poster and use that as a prompt as you're educating women on these maternal warning signs. But we really want to encourage women to seek help when they are concerned. It talks about, telling them how to call you, what to do in the middle of the night, what to do on a weekend. If you feel like you need emergency help, you need to call 911, or you can go to the hospital. So this can be tailored for each provider to direct the woman and her family on how they would like their patients to seek care if they have concerns. And looking at the next slide, we know that many of our hospitals, most of our birthing hospitals in Oklahoma are using the A1 post-birth warning signs. And these are a great tool to give then to reinforce these warning signs at discharge from the birthing hospitalization. So what ideally we would like to happen is that the woman receives this education. This is reinforced again, then she can be given the resource page that Sarah just described, so that a woman knows what to do if she has concerns, and ensuring that her family is also included, because sometimes the women may not be able to actually seek the care. Getting your emergency departments and the whole team anywhere that a woman might show up for care postpartum on board with this. So I think this is the last slide. Is that correct, Denise?
Yes, it's the last slide.
Okay, before we move to Dr. Jackson's presentation, Sarah, did you have anything to add? And we'll open it up for question comments also.
No, I don't think so. We did get a suggestion from Karen Ortiz, who suggested that we should use QR codes, and I think that's a great suggestion. We'll probably look into adding those in so people can have easier access to the websites. But yeah, that's it.
So we'll let you know as these become available. If you do have any other comments or suggestions, please feel free to reach out. And again, as Sarah mentioned, we will be launching soon a web page on our website that has more detailed resources. I saw a comment from Joni Bruce, like we would have Oklahoma Family Network as one of the links on that page. So there will be links to different support groups for different conditions. For example, the Amniotic Fluid Embolism Foundation has excellent support resources for providers and for the patients and families. So we will have that page will be available soon on our website. So be on the lookout, and we will let you know as these come out. Thanks, Sarah. So next on our agenda, as some of you know, the OSU Project ECHO launched some high-risk pregnancy Project Echoes back, I believe it was in September, but I am going to turn it over to Tara Jackson, who will be providing a presentation for us with more detail on the Project ECHO. And Dr. Jackson, if you want to go ahead, you can share your screen to show your presentation.
Thank you, everybody. Thank you for letting me present Project ECHO here today and our new high-risk OB ECHO line. It's very, very nice to see a lot of familiar names from the past work. So it's good to be back in this group again. I'm going to post just a quick survey regarding our high-risk OB ECHO before I start. And it just kind of gives, I would like to know basically more convenient times for the ECHO line, subjects that you would like to talk about. And you can take a look at that a little bit later. And I will attempt to share my screen here. Okay. Can you guys see that?
We can, thank you.
Excellent. So basically today, I'm just going to talk a little bit about what ECHO is, why ECHO is important, and the launch of our high-risk OB ECHO line. Basically, Project ECHO is an educational platform, and the goal of Project ECHO is to touch 1 billion lives around Oklahoma and the world by 2025. And actually, we think we're going to touch that 1 billion lives a lot sooner than that, sadly, because of COVID and all our efforts with COVID-19 ECHO lines. But again, touching 1 billion lives is pretty key. And I don't know if a lot of people know what Project ECHO is, but ECHO stands for Extension for Community Healthcare Outcomes. We've switched it a little bit to extension for community health outcomes in Oklahoma, because instead of just healthcare lines, we're also doing education lines to help our schools around Oklahoma. But today we're going to talk about our healthcare lines. Project ECHO was started in 2003 by Dr. Sanjeev Arora at University of New Mexico. And Dr. Arora is a hepatologist, and he was treating hepatitis C patients. And by the time they got to him, there was an 8-month waiting list usually for him. A lot of patients didn't want to travel to go see him because it would be a distance of 200 miles. And in 2003, being treated for hepatitis C took a lot of trips. So he's like, this has got to stop. And by the time they reached him, they had, liver cancer. So he said, this has to stop. So I'm going to teach people in rural communities or medically underserved communities to do what I do. And the whole idea is to share his knowledge and democratize knowledge. So he developed this model to increase capacity and access to specialty care for rural and underserved populations throughout the world, frankly. And the whole idea is to link expert interdisciplinary specialist teams with primary care clinicians in these underserved communities. And we do it through these tele-echo clinics. I know this is a word salad here, but it has some key points. The whole idea, it's just an innovative delivery model that can expand specialty care access to these underserved communities. And we do it through Zoom, these weekly video conferences, and we train and mentor primary care providers to care for patients who have these complex conditions in their own communities, instead of having to be transferred to urban centers. And they get the care they need from their own doctors without having to drive these long distances, without having to find childcare and actually going to the appointments. And so basically they get the right care in the right place at the right time. And overall, they found out that doing it through an ECHO or these training and mentoring sessions and seeing the care that patients are getting, the outcomes were the same, if not better, in these patients that were in these rural communities. And overall, it reduces costs to states as well. So Project ECHO, again, is an educational platform for the democratization of knowledge. And the whole idea is a force multiplier. It's not telemedicine, it's teleeducation. I'm going to teach you as a physician what I do, as a specialist, what I do for these common complex conditions so you can treat those patients. And it's an all teach, all learn environment. The whole idea is to develop this sense of collaboration and these knowledge sharing networks to easily share information in a very safe environment in order to better care for patients in the end. The whole idea is to address the key needs of a community or state, and the information always has to be cutting edge and evidence-based. And we'll talk a little bit more about how all that's done. We use a hub and spoke model, and the whole idea again is to flatten all these hierarchies in order to create this dialogue between all the participants. It reduces social and peer barriers, and the whole idea is to end needless suffering and reduce disparities to access to care. Dr. Arora always stated, Project ECHO works because it's simple. We basically use Zoom technology, and OSU Center for Health Sciences became a partner with University of New Mexico in 2016 to serve Oklahoma through Project ECHO. And at that time in 2016, not a lot of people knew what Zoom was. Unfortunately, through COVID, everybody knows what Zoom is now, but it does help with our ECHO. But we use Zoom, and so obviously it's a free web-based conferencing tool, video conferencing tool, and you can access it anywhere. And again, we use a hub and spoke model to reach participants across the state. This is kind of what an ECHO looks like. You can see the people sitting around the table. Those are our interdisciplinary specialty team. And so for a lot of our teams, we have a specialist, a physician. We have a psychologist. We have a social service coordinator as well. And anything that would help better serve the population for that specialty. And we connect with all the spokes around the state. And there are basically 4 principles to Project ECHO, and we use A, B, C, D, and it's amplification, And the whole idea is to use technology to leverage scarce resources. And those scarce resources are our specialists. And then, so we want to share best practices. We want to make sure everybody's practicing at the same level of medicine in order to reduce disparities in care. We want to use case-based learning in order to master complexity. A provider will present a case, and we do all sorts of clarifying questions, and then we give recommendations. And it shows providers how they would treat, if they were sending a patient to a specialist in an urban center, it would show how that specialist would treat that patient. And then we use web-based database to monitor our outcomes. So A, B, C, D, pretty simple. And again, the whole idea is to increase capacity to deliver best practices for underserved populations. And the idea is that in one echo session, from the information that is learned from both the didactic presentation and the case that is presented, a provider can treat 10 patients just from one echo session with that information that is learned. So you can see how if we have 10 providers on an echo session, how the knowledge will be shared so rapidly throughout the community. And again, it's 10 times or more impact. And basically it teaches providers to be the specialists for their communities and overall to conserve these scarce resources. And how do we choose how to do certain echo lines? Currently, I'll show you a list of our current echo lines. Currently, we have 18 healthcare echo lines and 5 education echo lines. But we choose them based on that they have to be common problems across a community or a state or country. And basically, but the management is complex. So they have to be taught how to manage these patients. And then there has to be evolving best practice guidelines. It has to be pretty solid information in order to disseminate it. And then high community need. And if we have an echo, it has to have high societal impact. We do have a few echo lines in the movement, as we call it, the echo movement, that do tend to very, very rare conditions. But the overall goal is that you do common complex conditions that will have high societal impact. And then the whole goal is if they're also that serious outcomes will occur if we do not address them. So we want to make sure that we solve these problems in these communities. So that's our selection criteria for an echo line. So again, OSU healthcare echo lines, we currently have 18. At the top there, we just started on September 17th, our high-risk OB echo line, and I'll go into more detail about that. And my apologies, there's a train going by. So we have our COVID-19 Oklahoma update echo. You can take a look at it. Adult mental health, addiction medicine, and pediatric obesity medicine were our first echo lines that we started. They're high need across our state, and they're common complex conditions. So you can take a look at that. And just to let you know, we're starting an end-of-life care echo soon as well. So again, we launched our high-risk OB echo September 17th. We were a lot of in partnership with OSDH. And it's been a long time in the making for this. So we're very pleased that this is launched. You can see our hub team and our hub and spoke model. So we have Dr. Stanley as for our MFM, Doctors Aaron Brown and Carlos Guevara from OSU, OBGYN, Regina Lewis, Family Medicine and Obstetrics, and Melissa Cito from the Oklahoma Healthcare Authority to provide those social service recommendations, which are key in these communities. We're holding the echo currently every first and third Thursday from 12 to 1 p.m. We found out for most of our echo lines that the most convenient time is over the lunch hour. You bring your lunch, you snack on it while we have this group discussion. And then, but we're kind of discovering that OBGYNs are a little different than the rest of the providers, and providers that work in this field are just a little bit different, a little harder to convene. So in that survey that I posted, please just let us know what might be a more convenient time and a more convenient frequency that you feel we could get more people to log in. You can see that the topics that we're discussing are common complex conditions and like hypertensive disease and pregnancy, reduction of racial and ethnic disparities, diabetes, very common. And then we're also discussing COVID-19 and pregnancy. And I'll tell you a little bit how an echo session works. Well, actually, let's go here. So obviously you guys know all of these facts. We know that there's a high need in Oklahoma for a high risk OB echo based on our criteria. For the past 18 years, in Oklahoma, an average of 11 women died of complications related to pregnancy. Nationally, 700 women die every year related to pregnancy. 41 out of 77 counties in Oklahoma are classified as maternity care deserts. So these are just key factors in choosing this echo line, and that it's high need. Also, this echo line is also in support of the State Maternal Health Innovation Program and also the Oklahoma Maternal Health Task Force. We're in that C column under innovation. So working together with everybody to hopefully decrease morbidity and mortality in Oklahoma. So basically an echo session, the whole idea is to develop this collaboration and this care for each other and these networks. And so we start with some introductions in order to get everybody on the same playing field. We go by first, last name. Eventually we take out the doctor part of it and just everybody is, by their first and last name. And then we go into a very brief didactic presentation, no more than 15 minutes, because we want to make sure it's not a webinar. We want to make sure it's not one-directional communication, that it's multi-directional communication for that collaboration. And then we have a provider in a rural community present a real case that they're having difficulty with. And we discuss that case thoroughly. It's de-identified. We ask, the whole discussion is around clarifying questions, and then we give recommendations. The spokes give recommendations on how they would treat that patient, and then our hub team gives the final recommendations on how they would treat that patient if that patient was sent to them. And then we type up those recommendations, and the provider can choose to implement them or not. And then the other key factor of this is if a case needs to be escalated to a higher level of care, they already have this network built in. And so they can easily navigate the system in order to get to higher levels of care. It's pretty easy to register. You just log into our website. It's a very quick registration form. It takes about a minute and a half to fill out. And you get a participation guide, on how to navigate Zoom, how to actually participate in the echo, and the flow of an echo. And then you get an invitation with connection information that's emailed to you, and all you do is click on the link, and that's kind of what the email looks like. And then you just click on this link down here, and it takes you right into the session. And the whole goal is to interconnect providers across Oklahoma in order to better serve our state. Working together, we're just better. And so the high risk OB echo can support providers in their contexts. It helps with provider isolation. It facilitates professional learning communities across the state, bridge equitable barriers, and addresses current issues through an interdisciplinary lens. And it reduces costs for the state overall. So basically, moving knowledge, not patients, encouraging collaboration, and building workforce capacity. That's Project Echo. And that's my information if you have any questions. And then otherwise, I will stop sharing. Oops.
Thank you, Dr. Jackson, for that presentation. Very, very good. We've had some questions in the chat in relation to, if you could put the link to go to join the Project Echo and get the guide, that would be great.
And this is Barbara. We also have on our website, on our calendar, any of the upcoming Project Echo meetings are in our calendar, and we have the link to register in within that, the information that you'll receive when you click on that within our calendars. That's available through the OPQIC website as well. And we will also place this link to the survey on the page that has all of our information about this meeting, and also include that in the email that we send after the meeting. Are there any other questions for Tara Jackson about Project ECHO before we move on?
Thank you, everybody.
Thank you. We appreciate your presentation. The next item on our agenda is to provide an update about the Oklahoma Mothers and Newborns Affected by Opioids, or OMNO. As you all know, this is one of the AIM safety bundles that was released or developed by the Council on Patient Safety and Women's Healthcare and implemented by AIM. AIM states are encouraged to implement this. So I wanted to provide you with a brief update on OMNO. We did, as going back a little bit further, we had our first kickoff meeting back in March, on March the 3rd of 2020. And then, as everyone knows, the next week, things kind of exploded. So we paused all of our activities for OMNO as hospitals were focusing on COVID. And then back in September, we had some virtual reboot meetings for 15 pilot hospitals. And since then, 2 decided to withdraw from the pilot, but we had 2 more hospitals who have joined, and I'll share those names here in a next slide. So we have had webinars on the database. We have a REDCap database for hospitals to enter their data on the different cases that they care for women with substance use or newborns who are exposed, opioid exposed newborns. And hospitals began the data entry on November 2nd. So I'll share a little bit about that data here in a minute. In November, we did provide a webinar on Chest Health, the Chest Health app, which is a way that's going to connect women to referrals and other resources. And we have that going through the process right now with hospitals obtaining BAAs for the Chest Health app. So hopefully soon, some of our hospitals providers can start using this app and connecting women to resources through this easy tool that's available via cell phone. So we'll let you know when those first hospitals start using it. We have monthly calls with hospitals ongoing, and they provide us with information on what's the latest, what their latest activities are, and we talk about different ways we can help them remove barriers and other things like that. We had discussed a learning session number 2 in March. And as you can see with this bottom comment on my slide, as of December, because of the hospital surge for COVID patients, several of our hospitals are now again on temporary hold because of COVID-19. So they're just not able to focus on especially for those hospitals that had not really begun to do work on this yet, it was hard for them to be initiating a new activity right now. But we do have hospitals that are continuing on. Most of these are hospitals that had already begun to work on this. This is a list of the OMNO hospitals. Originally, they were planned to have kickoff meetings in 2 different waves, but because we had to cancel those in-person meetings, they all attended the kickoff meeting together. So the next slide, I have some information on data entry. Oh, common area of focus, sorry. Many of our hospital teams, as Dr. Pierce had mentioned earlier, we are encouraging that all women who are seeking prenatal care and all women at the birth hospitalization are screened using a validated screening tool. This can also be part of the Chest Health app once we get that in place. So many of our hospitals are focusing on ensuring that their women are being screened during prenatal care so that the women who need these services are identified. We've provided education on our Omnil toolkit about the different guidelines. So hospitals are at various processes of implementing these guidelines and incorporating that into their EHR system. The hospitals I mentioned are also working on data collection. We have staff education on screening tools and documentation. One of the models of care that we're encouraging is Eat, Sleep, Console. So we're working on education models for that, and patient education as well as staff education. And provider education and involvement in these screening and the handouts for patients. Also ensuring that they are documenting appropriately so that these medical records will be coded appropriately as well. I mentioned this Chest Health app and the Eat, Sleep, Console app. And again, just that several of our hospitals are on temporary hold at this point. The next slide, looking at a high-level overview of our data, and this is current as of last week, 1 or 2 weeks ago. We've had 78 mothers that have been entered into our data portal. 73% of those mothers were on Sooner Care, whereas Sooner Care overall cares for usually around 60% of our births. 28% had 2 or less prenatal care visits, or 22 of these women. 42% received MAT during pregnancy, 33 women. And then information on the babies, we had 65% that had symptoms of opioid withdrawal, 19% that required pharmacologic treatment for NAS. 44% of these infants were receiving maternal or donor milk at discharge, and 35% were placed with other family members, foster or adoptive family. So that is our current very high level overview of our data. We are going to be doing more in-depth analysis as we receive more data and as we are able to make more correlations with these data. And if you'll go back to that slide, that is my final slide. Does anyone have questions or comments about Omno? I see a question from Dr. Lovelace. The lines of referral don't seem well defined and they don't want to be left holding the bag. Yeah, and I think your concern is a valid concern that has been present for a long time, and we are really hoping that with the Chest Health app, that those lines of referral will be more formalized and easy to use. The other resource that I can connect you to, Dr. Lovelace, on our website, we have a page that's dedicated to resources. And so some of these resources are included in this resource map. So what we would encourage providers to do is to explore this map and see what resources are available near you. and we're always welcome to get feedback on that map. But hopefully with the work that we're doing, we know that we're going to identify gaps. So, you know, sometimes there may not be resources out there, and then we will have more objective information to provide with those that provide these resources that, hey, this is an area where we need to develop some resources. So we understand that that may happen as we move forward with this work, but hopefully we can identify these gaps and narrow the gaps as we move forward. Does anyone else have any questions or comments? Yeah, for example, the STAR Clinic is an excellent resource for those in the central Oklahoma area, and hopefully we can get things like that expanded in other parts of the state. Okay, if there's no further questions, the next slide, any other business? Does anyone have anything else to share? Okay, I do want to provide some information on some upcoming events. So we have our Infant Mortality Alliance has some excellent webinars that are occurring monthly that are continuing through 2021. So these are the topics that are upcoming, and you can link to those to register on our calendar. So you can go to the infantmortalityalliance.org website there to find out more information. So these have really been excellent webinars. We also wanted to mention the Lady Charts conference that's coming up in February. There is a group called Matriarch that is dedicated to providing useful data regarding women's health and any other kinds of, not just health, but other issues. And they are having their upcoming second annual conference on February 15th and 16th. We have registration on our website. You can access our calendar at the link below. This is the direct registration link, and you can also access it through the opqic.org/calendar link to register for this. So we'd encourage you, this is all going to be virtual and it's no cost to attend this. I do want to mention there are a couple of national speakers that are going to be at Lady Charts. Dorothy Roberts is going to be speaking on calling out the call out culture. And also Joya Career Perry is an OBGYN who's also going to be speaking about health inequity in women's health. So we're excited to have those national speakers and welcome all of y'all to join and attend Lady Charts. And of course, our 9th annual Becoming Baby Friendly in Oklahoma Summit is coming up at the end of February. So the link to register is there on the left side, or you can link directly through our webpage through our calendar. And so I would encourage you, these are always, very informative, and would encourage anyone who's interested to register for the Becoming Baby Friendly in Oklahoma Summit coming up in February. Our next meeting will be April the 20th. We take a break in the summertime, and then we will have a meeting again October 19th, again from 5 to 7. So be on the lookout for information when we're sending out registration for our April 20th meeting. Put these on your calendar. And if anyone did not enter your participant name, we encourage you to do so now, especially if you have a name that we cannot identify you. For example, Sam's iPhone, we may not know who Sam is, or if you're here on a telephone, please just email us at info@opqic.org to say who you were, so we'll know who attended the meeting. And I think that's all. Chad, do you have anything else to add? Thank you all for being here this evening. We appreciate it. Please follow us, like us on Facebook, follow us on Twitter. We have YouTube account and Instagram. So these are all the relevant web information for you.
Yep, I was just going to add, Barbara, again, thank you to all the presenters. Lots of great information, a lot of great content, a lot of good work being done. Encourage you all to reach out, let us know how you want to help. And we thank you for all your hard work and efforts. Have a wonderful evening.